Good afternoon.
Good afternoon, sister.
Good
Good
afternoon,
afternoon, sister.
sister.
All right. So sorry for being late. I was stuck somewhere. Okay, please. Yeah. So before we start, can we have a word of prayer from Jennifer? Yes, Jennifer. Jennifer Anderson.
Yes, sister.
Please pray for us. Okay.
Okay, sister. Our Lord and Master Jesus, we thank you for this evening. Our prayer is that as we are about to learn, oh God, may you give us the understanding of whatever we will be taught, so that at the end we shall give good account. This and many more we ask through Jesus Christ our Lord. Amen.
Amen. Thank you so much, Jennifer. Okay. All right. So this afternoon, I want us to consider PPH. Okay, so I want us to consider PPH because I think last we started considering complications in puerperium or in the postpartum last week. And so today we are continuing by looking at postpartum hemorrhage, which is most common or one of the critical situation that happens or that mostly occur during postpartum, and especially in our part of the world. Uh, in our part of the world, we have most women experiencing it, and the unfortunate aspect being the mortality bit or the morbidity bit that are associated with this condition. So postpartum hemorrhage or PPH today. So our learning objectives by the end of this lecture, you should be able to define PPH, which I believe we are all not new to it. So at least I believe for those of you at the clinical field, probably you might have encountered some before, or you might have heard of some before, or those of us who are still at home, I believe definitely you've been taught during your that is the diploma at the diploma level. So basically it's not so much new thing that we are going to consider, but then let's see how best we will appreciate it, and also the new things that we can learn as far as the PPH is concerned. And so still, like as I said, once you are continuing your education, it's still also as a reminder or just to also boost your knowledge in the care that you can give if you are confronted with such a situation. So it's my hope and prayer that by the time we complete this lecture, uh, at any point in time, especially whether you are at the health center, at the CHIPS, or at the district, municipal, or anywhere, you should be able to at least attempt managing the woman experiencing PPH. And in fact, the management, I believe, is not so much an issue, but then the recognition, because that's one thing that most of the time I've come to see, that is the ability, that is a recognition. Yes, for most midwives, they are good. Yeah, hello, patient. Oh, it's a mistake. Okay. So for most midwives, yes, they are able to recognize it early, and most of the time, experience also counts. So the number of years of training also count in ability, that is picking up these signs and symptoms very early before they escalate or before they get worse and put the woman in danger. So yeah, so by the end of the day, you should be able to define it, or in case any junior colleague asks you, you should be able to tell or explain to the person and then distinguish between primary and secondary PPH. So basically, these are the two types we are going to consider. So primary and secondary PPH, and also explain the normal physiological mechanisms that prevent excessive bleeding after delivery. Also, you should be able to identify and explain the major causes of PPH using the 4Ts framework, which we are not new to it, like I said, and also recognize the clinical signs and symptoms of PPH and also assess their severity. So one, your ability to recognize, as I made mention at first, that is basically the fundamental. Once you are able to pick it up early, that is where the healing begins, or that is where I believe the management begins, from recognition. Because if you are not able to recognize it, then unfortunately, by the time you are able to detect it, which means that complications or the woman is already on its way, in a very critical situation. So yeah, so this describe the recognition, as I said, very important, and then describe the stepwise management of PPH, including the uterotonic medications, surgical interventions, and then the blood product replacement. Also, you should be able to explain the principles of active management of third stage of labor and its role in preventing PPH. This one, I'm told by Hajia that you at least she has touched some that is some points under these ones, that is active management of the third stage of labor. And also identify women at increased risk of PPH during the antenatal and then the intrapartum period. Describe the role of the midwife in the prevention, early detection, and management of PPH. And also, last but not the least, demonstrate an understanding of the emotional and psychological impact of PPH on women and their families, which is very, 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 very important, because most of the time we are more interested in stabilizing or resuscitating the woman, making sure she's fine. Once she's fine, most of the time we ignore the psychological and then the emotional bit of care that we have to give to this patient or this woman and her family. All right. So as a way of introduction, sorry, maybe I may be moving fast. So in case that is, you are not getting it, that is, if you think I'm moving too fast, you can just let me. Okay, so we are saying that postpartum is one of the leading causes of maternal mortality and morbidity, not only in Ghana, but also worldwide, is one of the leading mortality and morbidity. And it is responsible for approximately 27% of all maternal deaths globally, making it the single most common cause of maternal death, particularly in low and middle income countries where Ghana, we also belong. So where Ghana is also part when we consider the low and middle income countries. Okay, so even in high resource settings with advanced healthcare, PPH remains a significant obstetric emergency that every midwife must be fully prepared to recognize and respond to. So the term postpartum, already we know postpartum, what it means after delivery, and then bleeding. So, or hemorrhage means severe or uncontrolled bleeding. So hemorrhage means severe or uncontrolled bleeding. So PPH therefore refers to, that is in simple terms, excessive blood loss occurring after the birth of a baby. excessive blood loss occurring after the birth of a baby. So what makes PPH particularly dangerous is that it can develop very rapidly, and a woman can lose a life-threatening amount of blood within minutes. So as an emphasis, early recognition and prompt coordinated action. So early recognition, prompt, coordinated action are therefore absolutely critical. So, which in fact, that is where my interest or my passion really lies in the early recognition, the prompt management, and then the coordinated action that are very necessary or very important to that is leading to the road where the woman can find recovery. So as a midwife, you will be present at birth throughout your career, and the ability to anticipate, recognize, and respond to PPH with confidence and competence is one of the most important clinical skills you will develop. So as I said, definitely that is my aim, or the goal is that at the end of the day, wherever you find yourself being a midwife, definitely. So unless maybe you decide to come to the classroom, but then once you are a midwife and you remain at the clinical field, you will come across that is helping a woman to deliver. And if you come across this thing, you should be able to, one, anticipate it early, recognize it, and also respond to it with all confidence and the competence, which is very important, um, which is very necessary in helping the woman to recover. So we have a tall list of definition of postpartum hemorrhage. So let's see. So with the traditional definition of PPH, it's a blood loss of what, 500 mils or more following vaginal delivery. Okay, so however, maybe I should bring this one down. But however, it is increasingly recognized by organizations such as the World Health Organization, that is the WHO, and the Royal College of Obstetricians and Gynecologists, that any blood, so they define PPH as any blood loss that causes hemodynamic instability. So traditionally, we were looking at when we measure 500 or more that is bleeding following vaginal delivery and 1,000 or more following CS within the first 24 hours. That is where we now begin to run around that the woman is having PPH. But then research evidence by these organizations, that is the WHO and then the RCOG, is now defining PPH as any amount of blood loss, because individual mothers are different. And most of the time, don't also forget that, especially in our part of the world, most women, in fact, by the time they start even with pregnancy, they are already anemic. For some women, already by the time they start pregnancy or they begin pregnancy, you realize that they are already anemic. And so throughout ANC period, it's like they are battling with trying to boost their hemoglobin level and all that. And so looking at this woman already, that is maybe, let's say, for example, even if her HB will come up, it may not come up to, let's say, around 11 or even up to 12. So let's say this woman going into labor and then developing PPH. And for most women with anemia, and I think those of you at the clinical field will attest to it, that in fact is one of the risk factors has to do with a woman with anemia. A woman with anemia, they are people who are at risk of PPH. And so with such a person, she doesn't need to lose that quantum of bleeding. before we now run around saying that she's having PPH. So that is why through research, with the WHO and the other organizations, they are saying that any blood loss that causes hemodynamic instability. So once we realize that the woman is not well or is unwell, she's losing blood, passing clots of blood, then we quickly, that is where we quickly need to intervene than trying to measure before we will say that, oh, this is not bleeding, it's rather look here and a whole lot. Okay, so basically this is what the current meaning or definition put it. So meaning it affects the woman's blood pressure. So the moment we check the vital signs, which has to do with the blood pressure, the pulse, or the general condition should be treated as PPH regardless of the measured volume. So here, with other explanation that I've put to it, says that this distinction is very important in clinical practice because blood loss is notoriously difficult to measure accurately. So, and interestingly, with our part of the world, and it's difficult because, like as as the explanation put it, because most of the time, the woman is done, you delivering, you've removed the placenta. Then the next moment you tell the woman, oh, maybe Auntie Mansa put the part there. Auntie Mansa will put the part there. But then, so the issue is when she starts losing blood and, she's going to lie down. So it will be difficult to accurately measure the blood loss. That is, yes, measure the blood loss. So here, that is why it's saying that this distinction is very important in clinical practice because blood loss is notoriously difficult to measure accurately. And blood loss is consistently underestimated by clinicians, sometimes by as much as 50%. So furthermore, women with pre-existing anemia, like as I've already explained, or who are small in stature, may deteriorate significantly with a blood loss that might be correlated by a heavier or larger woman. So please let's take note of these because these are real life situations. So where research have identified that women with pre-existing anemia or who are small in stature may deteriorate. So small in stature, maybe I'm sure some people are looking at, oh, the person is short, the person is smallish, but small in stature also has to do with especially those who are undernourished, those women who are undernourished or those women like probably throughout pregnancy, they've not been eating well, they've not been taking good care of themselves well. And so, in terms of their BMI or in terms of weight gain that they are supposed to gain during pregnancy, they might not have reached that good weight gain. So that's what they are referring to. So here is referring to those who are small in stature may deteriorate significantly with a blood loss that might be tolerated by a higher or heavier woman. So the midwife must therefore assess the woman's clinical condition alongside the estimated blood loss, not rely on volume alone. So PPH is further classified by severity into minor PPH. So we have minor PPH, which is between 500 to 1,000 mils without clinical shock. Then major PPH, maybe I should have brought these ones down. Okay, so we have minor PPH. So that is between 500 to 1,000 milliliters, milliliters without clinical shock. Then we have major PPH more than 1,000 or any amount causing hemodynamic instability. And then we have what you call massive PPH. So Yes, so for massive PPH, more than 2,000 milliliters or requiring blood transfusion or more than 10 units of packed red cells. So this represents a life-threatening emergency, so especially when under the massive PPH. So let's look at classification by time of onset. So time of onset, that is time when it starts. So PPH is classified into two broad types based on when it occurs after delivery. So based on when it occurs after delivery, one, we have primary PPH. So with a primary PPH, we are saying that it occurs within the first 24 hours after delivery. So it occurs 24 hours after delivery. This is far the most common type of the most immediately life-threatening. It usually occurs in the immediate postpartum period and often within the first hour, that is first 1 hour. So that is usually, though we consider the first 24 hours after delivery, so any bleeding between that time. But then usually in the immediate postpartum period, often within the first hour. So at times, sometimes called the fourth stage of labor, because it requires just as much careful monitoring as labor itself. Okay. As labor itself, yes. So normally we call it the fourth stage of labor because, like I said here, so basically it requires, so with the first 1 hour especially, requires a monitoring, a careful monitoring of the woman. And so such that is similar as the way we monitor, we do a careful monitoring of labor. So that's why we call it fourth stage of labor, because it also requires, or continuously, it requires a careful monitoring by the midwife. So the vast majority of primary PPH cases are caused by uterine atony, that is, when there is failure of the uterus to contract properly. Let's look at the secondary PPH. Later, we will take them one by one and then look at the causes as well. Okay, so with a secondary PPH, we say that it occurs between 24 hours and 12 weeks after delivery. So between the first, that's between 24 hours, because we've said that with the primary one occurs within the first 24 hours after delivery. And so with the secondary one continues. So when bleeding begins after that is with heavy clots and all that, begins after 24 hours to 12 weeks after delivery, though that they are considered, that is secondary PPH. Though most cases present in the first 2 weeks. So in the first 2 weeks still account for secondary PPH. So it is less common compared to the primary PPH, but still can be serious, or can be a serious condition. So the most common causes of secondary PPH are retained product of conception. So when there's pieces of placenta or membranes that were not fully expelled at delivery, they are locked in there. And then also infection. So infection, which is endometritis. I think that last week we considered puerperal sepsis, so, or puerperal infection. And if you remember, we talked about that. So we have infection. Infection is one of the contribution to secondary PPH. So endometritis, especially, often that is infection of the uterine lining. So women with secondary PPH most often present after they have been discharged from the maternity unit. So they may come through the community midwifery service. So that is, through that is community. Anyway, we usually, anyway, those referring to those midwives who are the chiefs or who are posted to the chiefs or health centers. So they may find themselves going through them or the general, which is the what do we call them? These physician assistants, or sometimes they may also come to the emergency department, depending on the severity of that is, or the signs and symptoms a woman may be manifesting. So community midwives and practice nurses must therefore also be alert to this condition. So in training them, which I believe, well, I don't know much when it comes to your CPDs, but I believe these people are all included when it comes to training them on management or resuscitation, um, as far as PPH is concerned. Okay, so briefly, let's look at the physiology of normal postpartum homeostasis. So normally, what's supposed to be the case where there's no, like I always say that where there's no PPH. So normally, what is supposed to be the normal postpartum homeostasis? So here, I said to understand why PPH occurs, it is important to first understand how the body normally prevents excessive bleeding after delivery. So here, the placenta is attached to the uterine wall. So I need you to get a picture, and I believe, well, you already have that in mind. So here, the placenta is attached to the uterine wall during conception, and so via a large network of blood vessels. And if you remember your embryology and then fertilization and implantation very well, you know, during that time, there are new vessels that are formed. There are new vessels that are formed, especially where the placenta is attached, so that there can be that transfer of nutrients and oxygen and all that from the mother to that of the fetus. Okay, so here, note that, so there's a significant hemorrhage. Okay, so there are a large network of blood vessels that are attached to where the uterine wall, where the placenta is. So at the moment the placenta separates and is delivered, these vessels are exposed and without effective homeostasis. And I believe if I say homeostasis, we appreciate or we understand what homeostasis means. So that is the ability of the body to control bleeding. So without effective homeostasis, significant hemorrhage would occur from the placental site. So the body uses two key mechanisms to prevent this. So the first is what we call myometrial contraction. So after the baby and the placenta are delivered, the uterine muscles, which is the myometrium, contract powerfully. So these contractions physically compresses the blood vessels at the placental site, so acting like a physiological tourniquet. So the way we use tourniquet to tie, that is to tie somebody's hand and we want to identify a vein. So these myometrial muscles, or the myometrium, contract powerfully. And what they does is that they help constrict, or they help actually, yes, constrict the blood vessels. So this is sometimes described as the living ligature. The living ligature effect of the uterine muscle. So the second mechanism, so we say that there's two mechanisms. So the first has to do with the myometrial contraction, and then the second is the coagulation cascade, what we refer to as the coagulation cascade. So in which the normal clotting system forms a blood clot to seal off the open vessels at the placental site. So these two mechanisms, that's what they work together, and a failure in either one can result in PPH. So you can see this simple, well, I am calling it simple, but you can see this naturally occurring mechanism to control bleeding. So here, what he's saying is that if any one of them fails, for example, if the myometrial contraction fails, and I believe if I ask why the myometrial examples of what will cause the myometrial contraction to fail, we can say, or we can, yes, we can discuss it, like when there is when there is retained product of conception. So these are all something that prevents it from contracting. And in effect, what preventing this physiological contraction or physiological compression of the, that is arresting blood vessels, that the bleeding can occur. And then when we also talked about the coagulation cascade, that is when the normal clotting system forming blood clots to seal off the open vessels at the placental site is not there. So when it's not there, or when the woman is lacking, then unfortunately, any one of them lacking will lead to PPH. So the single most important protective mechanism is uterine contraction. So if the uterus does not contract firmly and consistently after delivery, massive hemorrhage can occur very quickly. So this is why uterotonic drugs, that is drugs that stimulate uterine contraction, are such a cornerstone of both PPH prevention and then treatment. So now let's look at the four causes of, that is the 4Ts framework. So which are also referred to as what? The causes of PPH. So the causes of PPH can helpfully organized using the mnemonic, the 4Ts, which is tone, trauma, tissue, and then thrombin. So this framework is widely used in clinical practice and helps ensure that all potential causes are systematically considered when managing a woman with PPH. So let's look at the first T. So the first T is tone. So when we refer to tone, we are referring to the uterine atony. So that is the uterine tone, or basically what we are referring to is the ability of the uterus to contract firmly, consistently. So when there is tone, that is what we are referring to. But then in the case of what causes an PPH, then we are talking about uterine atony. So which is most common cause. So here we are saying that the tone here as the first T refers to uterine atony, which is the failure of the uterus to contract adequately after delivery. So failure of the uterus to contract adequately after delivery. So uterine atony accounts for approximately 70 to 80% of all cases of PPH, making it by far the most important cause to understand and then manage. So if there is anything that we need to understand very well, and especially in our part of the world as midwives, then we need to appreciate why tone is an important cause, or uterine atony is an important cause of PPH. So a uterus that is soft, boggy, and poorly contracted after delivery is a hallmark of uterine atony. So several risk factors predispose a woman to uterine atony. So the first one, we have an over distended uterus. So such as occurs with a large baby. So in macrosomial babies, multiple pregnancy, which is twins or more, or polyhydramnios. So when there's polyhydramnios, which is excessive amniotic fluid. So for that one, so we are saying that it's a risk because the overstretched muscle fibers contract less effectively. So a prolonged or augmented labor exhausts the uterine muscles. So which is very, very important part to also take note of. So a prolonged okay, let me add this one too. Okay. So over the extended uterus, so these ones are all parts. So a large baby, multiple pregnancy, and that is polyhydramnios, which is excessive amniotic fluid, is at risk because that is overstretched muscle fibers contract less effectively. Then also we have a prolonged or augmented labor exhaust the uterine muscle. So when we keep repeating, augmenting, pushing, that is augmenting labor. So please, we need to take very critical look at this one too, because when we continuously repeating, augment, that is trying to augment labor, what happens is that it exhausts the uterine muscle. And so at the time where we want it to contract to control bleeding, it's not able to do that. So when there's a prolonged or augmented labor, exhaust the uterine muscle. Then also in grand multiparity, so a woman who has had 5 or more previous births is also at risk factor, or is also a risk factor, as the uterine muscle may be less responsive. Then also we have general anesthesia. We have chorioamnitis, that is uterine infection. We have use of certain drugs such as tocolytics, that is drugs that relax the uterus, and also uterine fibroids that distort the uterine cavity can all contribute to what? To atony. So a woman who undergoes general anesthesia, chorioamnitis, uterine, that is leading to uterine infection, use of certain drugs, or use of that is tocolytics drugs. So they all account for, that is a delay, or that is unresponsive or less responsive uterine muscle. So however, it is critically important to note that uterine atony can and does occur in women with no identified risk factors. So much as we've mentioned this, most of the time or sometimes these women can even be okay to manage. But then there are situations where you should also note that, uterine atony can and does occur in women with no identified risk factors. So there are some women who may not have these or the above mentioned risk factors. So which is why every woman must be closely monitored in the immediate postpartum period, regardless of her risk status. So every woman, so especially within the first 24 hours. So anye bia kran the first 24 hours or the first 1 hour to 24 hours, at least the woman should spend that time at the ward for monitoring, for careful monitoring before we discharge the woman home. So quickly, let's look at trauma. So trauma is the second most common cause. Yes, so trauma, sorry. So trauma is the second most common cause, and trauma refers to any injury to the genital tract that causes bleeding. So any injury to the genital tract that causes bleeding. So this includes lacerations, that is tears of the perineum, vagina. Sorry. So this includes tears of the perineum, vagina, and cervix that occur during delivery. So tears are classified into 4 degrees, and especially when we consider episiotomy. Please, sisters, just give me just one. Yeah, so we are saying that, yeah, so tests are classified into 4. So we have the first degree that involves the skin only. That So we have the first degree that involves the skin only. The second degree involves the perineal muscles. The third degree involves the anal sphincter. And then the fourth degree extends into the rectal mucosa. Okay. So with the trauma, like I said, vaginal and cervical lacerations can bleed very significantly, particularly from the highly vascular cervix. So most of the time, or specifically the cervix where it's more vascular. So trauma also includes uterine rupture, though very rare, but can be but can be very severe or catastrophic tearing of the uterine wall. So most commonly seen in women with a previous cesarean section scar. And then we also have uterine inversion. So uterine inversion, which is equally real, but then can also be a very dramatic emergency in which the uterus line literally turns inside out. So definitely you've heard of uterine inversion, and is when the uterus turns inside out, and most often caused by excessive traction on the umbilical cord or fundal pressure before the placenta has separated. So this actually results in the uterus turning inside out. So note that trauma-related PPH should always be suspected when the uterus is well contracted and firm. So trauma-related PPA. So unlike the tone where we are looking at uterine atony, so with a with a trauma, it can occur though, should always be suspected when the uterus is well contracted and firm. So which means that tone is not the issue here, but bleeding, you still see bleeding continuing. So here you realize that in terms of the contraction, that is the muscle or the uterus is contracting well and consistently, but then the woman is still bleeding. So that is why you have to immediately look out for any trauma or the woman sustaining any trauma or any tear. Okay, so the third one, let's quickly look at that has to do with tissue. So in terms of tissue, it has to do with retained product when there's a retained product of conception. So tissue refers to retained placental tissue or membranes within the uterus. If pieces of placenta or membranes are left behind after delivery, they prevent the uterus from contracting fully because the uterus cannot clamp down properly over remaining product that is locked in there. Okay, so this is a cause of both primary and secondary PPH. So with the retained or with a tissue or retained product of conception can occur both during the primary or can be a secondary cause of PPH. So with the tissue retained product, we also have what we call, so most of what causes it has to do with what we refer to as a morbidly what adherent placenta. So when we refer to a morbidly adherent placenta, has to do with a spectrum of conditions, including that is all those conditions that involved placenta. So for example, we have placenta accreta, we have increta, we have percreta, where the placenta abnormally invades what? The uterine wall. And so they represent the most severe form of tissue-related PPH and is a major cause of what we refer to as catastrophic hemorrhage requiring surgical intervention. Because this one, it's not about like it's not about trauma where you will say that, okay, let me then suture or identify the trauma and suture. But this one is when we talk about the placenta accreta, increta, they invade the uterine wall. And so most of the time, that's why we are saying that they are catastrophic hemorrhage, because you cannot manually manage it, but it will require what? Surgical intervention, and including hysterectomy in severe cases. So in severe cases, hysterectomy, there may be no other option than hysterectomy that has to be done. So after delivery, the placenta and membranes must be carefully inspected to confirm that they are complete. So which is very, very important. And these are the roles of the midwife. So you inspect the placenta to make sure that all the membranes are complete. So any missing cotyledon or segment of the placenta or obvious defect in the membranes must be reported immediately, as this indicates retained tissue requiring further assessment and treatment. So let's look at the thrombin. So which is the 4T, which is thrombin, has to do with coagulation disorders. So thrombin refers to coagulopathy, meaning a failure of the blood's normal clotting mechanism. So this may be a pre-existing condition such as von Willebrand disease, and I believe this is a genetic is a genetic condition, or hemophilia. The woman may be a hemophilia carrier status or immune thrombocytopenic purpura. So all these are like more has to do with genetic. Okay, so a condition that developed during pregnancy, such as the HELP syndrome, which has to do with hemolysis, elevated liver enzymes. Then we have low platelet, or what we also refer to as acute fatty liver of pregnancy, or a coagulopathy that develops as a result of the PPH itself. So the unfortunate aspect is that PPH itself also can lead to the woman developing coagulopathy, because the more the person is losing blood, unfortunately, the person also begins to lose the clotting factors that may aid with that is to help stop bleeding. So this last point, which is the coagulopathy or the thrombin, is very, very important, because massive hemorrhage leads to consumption and dilution of clotting factors. So severe PPH from any cause can trigger DIC. So please take note of this. So severe PPH from any cause, so from any of the T's, whether tone, whether trauma, whether tissue, whether thrombin, can lead to what? Can trigger what you call DIC, creating a vicious cycle in which the bleeding causes causes more clotting failure, which causes more bleeding. So, which means that PPH itself or massive PPH itself can lead to what? DIC. And unfortunately, when DIC sets in, it will have to take place for the woman to actually survive. So because the more that is with the PPH leading or triggering DIC, what happens is that the woman begins to lose more blood. There's more bleeding, which becomes difficult to control. And so placenta abruption, which is premature separation of the placenta, is also another important cause of coagulopathy-related PPH. So placenta abruption, especially the conceived one, is another important cause of coagulopathy-related PPH. So quickly, let's look at risk factors. So understanding risk factors allows the midwife to identify women who need enhanced monitoring or careful monitoring and preparation. So though, as noted above, PPH can occur in any woman. So like as I've made mention already, that even when the woman may not have any risk factor, we still need to do our careful monitoring because, it can still happen even though the woman may not show any or may not have any risk factors. But then we are looking at the risk factors, or in case we have to be sure so that we can monitor and prepare the woman well, that is through labor and postpartum. We need to be able to, there's some identifiable risk factors we can take note of. So risk factors are usefully categorized into antenatal, intrapartum, and then patient-specific factors. So for the antenatal risk factors, it includes one, a previous history of PPH. So this is one of the strongest predictors, a previous history of PPH. Then we have placenta previa. When there's a low-lying placenta, the moment during the ANC, you recognize that you should, in fact, mark the ANC book so that this woman should be well monitored, so that during delivery we ensure that a skilled, that is if only she will deliver per vagina, depending on the types. We have types of placenta previa. So depending on the type, there's the first type, the woman can deliver per vagina, but then with careful monitoring and by an experienced midwife. Unlike the rest, the woman has to be delivered or has to be taken to the theater. So for such a person, we mark the person as a risk factor, that is having a risk of what? Of PPH. Then also when there is suspected placenta accreta or morbidity adherent placenta, morbidly adherent placenta, like what I've already mentioned when it comes to placenta accreta, increta, percreta, and all the craters. So they are all, we should suspect that is a sign, or it means that the woman is at risk of that. Then multiple pregnancy, grand multiparity, polyhydramnios, large fibroids, preeclampsia, or hypertensive disorders of pregnancy also put the woman at risk of what? Of PPH. Then also pre-existing coagulation disorders pre-existing coagulation disorders, then also a significant anemia at the onset of labor, which means the woman has less physiological reserve. In case of intrapartum risk factors, we have prolonged labor in first stage, second, and then the third stage. Then emergency cesarean section can also trigger PPH. Then also instrumental delivery, forceps or ventus can trigger PPH. Oxytocin, especially with the trauma, that is with the trauma, instrumental delivery can lead to trauma. Then oxytocin, augmentation of labor, chorioamnitis, precipitate labor, very rapid labor, then macrosomial and shoulder dystocia. So where there's difficulty delivering the baby's shoulder, which is associated with uterine atony. Okay, so it must be stressed that these risk factors should be used to guide preparation and vigilance, not to create a false sense of security or insecurity. Let me put it that way, insecurity in women without them. So, these are basically the risk factors. Already, I've already made mention of them, but I've brought it back again. But just for us to prepare, to guide our preparation, and also be vigilant, But then it's not to, like I said, create a sense of insecurity in women without, to create a sense of security in women without them. Because already I've made mention that even those without these, that is, without these risk factors, PPH, they can still experience PPH. So in practice, many women who experience PPH have no identifiable risk factors beforehand. And so that is why sometimes as midwives, it takes us unaware because everything is fine, shows that the woman is fine. Then all of a sudden, she begins to experience that. Let's look at clinical signs and recognition of PPH. So one, recognizing abnormal bleeding. So because one will ask that definitely, doctor, the woman is supposed to bleed during after delivery. That is where we've looked at as the lochia. So at that time, let's say within the first 24 hours, so the woman is having, experiencing lochia rubra. So how do I recognize that this time the woman is having a PPH, but is not just the normal bleeding? Okay, so first we are saying that the midwife must be able to distinguish normal postpartum blood loss from what? The abnormal bleeding. So after a vaginal delivery, some blood loss is expected and normal. Like I've explained, the lochia rubra, we expect it to come. But then how do we then recognize that no, this one we have to put in intervention? So the loss becomes abnormal when it is heavy and continuous. When it is heavy, it's like it's just coming, or it keeps coming, or the woman keeps pouring. So when it is heavy and continuous, when clots are being passed, when the woman is showing signs of hemodynamic compromise. So for example, if you check the BP, you realize that the BP is dropping. The pulse is rapid and very, 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 we call it ready, but then very faint. So you realize that no, or what happened is that, or when the uterus is felt to be soft and boggy rather than firm and contracting or contracted. So when we realize these signs, there's heavy and continuous pouring. That is, the woman is just pouring blood So I remember when we were treating Lokia, if you remember, I said when the woman can change pad within, that is two parts within, I think within 2 hours. Yes, when the woman change parts within, that is within 2 hours, it means that she is bleeding. And when clots are being passed so much, and then when the woman is showing signs of hemodynamic compromise. So, and with the hemodynamic compromise, I've explained in terms of the BP dropping, the woman feeling cold to touch, the pulse steady and faint, then you need to suspect, immediately suspect that. Or when the uterus, you touch the uterus, it felt so soft and then boggy rather than firm and contracted. So signs and symptoms of hemodynamic compromise. So as blood loss increases, the body activates what we call compensatory mechanisms to maintain blood pressure. And these responses what produce recognizable clinical signs. So we are dealing with signs and symptoms of hemodynamic compromise. So how do I uh, realize, or how do I know what hemodynamic compromise means? So we are saying that as the woman loses blood, or as blood loss increases, the body activates its own compensatory mechanisms to maintain blood pressure. And these responses produce recognizable what? Clinical signs. So we have in early stages, the woman may appear anxious or restless. So you will see this woman, oh, this woman, you've delivered the woman peacefully. She's gone back to bed. Then all of a sudden, you see the woman being anxious, being restless. The pulse rate increases, so there is tachycardia, and the skin becomes pale, cool, and clammy. So when the skin becomes, you touch the skin, it's pale, it's cool, and clammy, then you should immediately, so that is the early stage, what happens. So you will see the woman becoming restless and anxious. So mostly they will start shouting and say, Auntie Midwife, as I'm a honye. And that is what, well, in other languages, I don't know how they will put it, but mostly in Tree, that's what they will say. They will say, Auntie Midwife, as I'm a honye, because they don't really see what is happening. But then they begins to feel unwell. So they will say it, or they will verbalize it that they are not feeling well. They become anxious. Then when you check the pulse rate, immediately you realize there's tachycardia. You touch their skin, it looks cool, and then clammy. So clammy means, especially, when somebody is dying, sometimes you see the way their skin is like the blood, there's blood draining from, even from the skin surface, then also pale. So as blood loss continues, blood pressure begins to fall. So there's hypotension, breathing becomes rapid, tachypnea, there's urine output decreases, which is oliguria, and then the woman may feel faint, dizzy, or nauseated. Then in severe cases, so in severe hemorrhage, the woman may become confused, will lose consciousness and enter what we call circulatory collapse and cardiac arrest. So in severe hemorrhage, the woman may become confused, lose consciousness, and enter circulatory collapse and cardiac arrest. So here, note that a very important clinical concept here is that healthy young women can compensate remarkably well for significant blood loss, and blood pressure may fall, or may not fall until 30 to 40% of circulating blood volume has been lost. So when about 40, so in younger women, where, they still have, most of their internal organs are still strong, what happens is that they are able to sustain, even though they are bleeding, but then they are able to, their system are able to help them compensate for the blood loss. But then not until where it's about the blood pressure falls about 30 to 40% of circulating blood volume has been lost, then that is where they begin to show the severe signs and symptoms. So by the time hypotension is apparent, the situation is already critical. So especially for these young people. So the midwife must therefore not wait for a fall in blood pressure before acting. So please take note, critical note of this. So you shouldn't wait because, like, I think you are the very group I told about. That is a student of mine, though she became more like a daughter to me, who, when she was good, because it's her first time, she's young, and they thought everything is well, though she was complaining. But then, unfortunately, the unfortunate incident happened before they realized that, not knowing she was in a critical condition. And so here, what it's saying is that we shouldn't wait for, because definitely in a younger woman, in adolescents, in young women, because their compensatory mechanism can help them or can support them remarkably, though they are losing blood, but then until the BP drops to about 30 to 40% of their normal BP. So here, like as I said, we shouldn't wait because by the time the person goes into hypotension, it would be that is, it will be critical, or the mother will be in a critical situation already. So the midwife must therefore not wait for a fall in blood pressure before acting. An increasing pulse rate, increasing pallor, or a woman who says she feels not right should trigger immediate assessment and what? Escalation. Okay, so uterine assessment, that leads us to uterine assessment. So if we say uterine assessment, or for uterine assessment, it's a systematic assessment of the uterus, um, which is a fundamental clinical skill for every midwife. Oh, okay. But is Hajia coming?